All right, let's get right into it. Today, we're putting you in the hot seat for a classic general surgery viva exam. I'll be the examiner, you're the candidate. The topic is hyperparathyroidism. Ready? Let's begin. Okay, the clock starts now. A 43-year-old female patient is referred from a primary care physician due to hypercalcemia. How will you approach this patient? The first thing you've got to do is show me you have a safe, logical system. Don't just jump to the answer. Start from the very beginning.
So I'd start by giving the examiner a roadmap. I'd say, my answer will cover the patient workup, how I'd form a diagnosis, the surgical plan, the key operative steps, post-op care and potential complications, and then I'll summarize the key takeaways. This shows them right away that you're organized and you know what you're doing.
All right, first up, the fundamentals. The first part of any good answer is going to focus on a really thorough history and a targeted physical exam. This is where you gather all your initial clues.
A structured history like this helps you narrow things down fast. You have to ask about the classic stones, bones, abdominal groans, and psychic moans, so that's your renal, bone, and GI questions. But you also have to look for red flags. I'd specifically ask about hoarseness. That could point to nerve involvement. And I definitely screen for symptoms of MEN syndromes to show I'm thinking broadly. Then comes the physical exam. After the basics like vital signs, you zoom right in on the neck. I'd watch for any swelling as the patient swallows. Then, and this is key, I'd move behind the patient to palpate. This helps relax their neck muscles. I'm feeling for any masses, checking if the trachea is central, and super importantly, feeling for any sneaky cervical lymph nodes.
Okay, so you've gathered your data from the history and exam. What's next? Well, now it's time to act like a detective. You need to come up with a list of suspects, your differential diagnosis, and figure out what tests you need to nail the culprit.
My list of differentials for high calcium would absolutely have hyperparathyroidism at the top. But you can't stop there. You have to show the examiner you're thinking about other big possibilities, like malignancy or even side effects from medications like thiazides. Mentioning less common causes like TB shows you've got a really comprehensive knowledge base.
Now here's a huge high-yield point for your exam. If your workup points towards parathyroid hyperplasia, where all the glands are enlarged, the definitive next step isn't another scan. It's actually a bilateral neck exploration. Trying to find the worst gland with a scan is usually a waste of time. This is a classic point that separates the good candidates from the great ones.
So we've settled on a diagnosis of hyperplasia, and we know surgery is the answer. Now comes the really important part, deciding on the right surgical plan. And the examiner will lean in and say, okay, candidate, investigations confirm parathyroid hyperplasia. What are your definitive surgical options? They want to see if you can think like a surgeon and weigh the risks and benefits of different approaches.
This slide lays out the two main choices. I'd explain it like this. You can do a subtotal parathyroidectomy where you take out 3.5 glands. The big pro? A lower chance of leaving the patient with permanent hypoparathyroidism. The con? The disease can come back, and a redo neck operation is, well, it's no fun for anyone. The other option is taking them all out and transplanting a piece of one gland into the forearm. The amazing thing about this is if it comes back, you just do a small operation on the arm. The major downside, though, is that the graft can fail, leaving the patient with really severe, permanent low calcium. It's a tough choice.
All right, let's step into the operating room. The examiner wants to know you can do more than just talk a good game. You need to walk them through the procedure, showing them you know your anatomy and how to be safe.
I talk them through it systematically. Make a standard collar incision, raise the flaps, divide the strap muscles, then you mobilize the thyroid lobe, ligate the middle thyroid vein, and then you get to the most important step of the entire operation. You find and you protect that recurrent laryngeal nerve. Only after that nerve is safe do you go hunting for all 4 parathyroid glands.
And this image right here shows the single most critical piece of anatomy you need to know. The recurrent laryngeal nerve is your compass. The superior gland is almost always found dorsal to it, behind it, and the inferior gland is ventral, in front of it. You have to know this relationship cold.
Then comes the classic viva problem-solving question. The examiner is going to say, okay, you're in the OR. You can't find the left inferior gland where it's supposed to be. Where do you look next? Panicking here is an instant fail. You need a calm, systematic search pattern. So, my answer would follow this map. The inferior glands come down with the thymus gland during development, so the first place I'm looking is in the thyrothymic ligament. That's A. Not there? Okay, next I check the carotid sheath, B. Still no luck? Then I have to consider that it might actually be inside the thyroid itself, C, and that changes things quite a bit.
And just to show I've really done my homework, I'd also mention that the superior glands can be ectopic too. It's less common, but if one's missing, you need to know to look in the tracheoesophageal groove, the carotid sheath, or even behind the esophagus.
But look, the surgery isn't over when the last stitch goes in. A really good surgeon is already thinking about what can go wrong and how to manage it. This last phase of care is absolutely critical.
So I'd list the potential complications, but I'd highlight the ones that can kill the patient. A neck hematoma after the surgery is a surgical emergency that can close off the airway in minutes. Nerve injury is a big deal, causing hoarseness. And of course, you have to be ready for the patient's calcium to drop.
And to really impress the examiner, you don't just say hypocalcemia. You specifically define bone hunger syndrome. This isn't just a small dip in calcium. This is a profound, long-lasting drop because the patient's bones, which have been starved for calcium for years, suddenly start sucking it all out of the blood. It shows a much deeper level of understanding.
So, what's the plan to prevent a crisis? It's simple and direct. Every single one of these patients should start on oral calcium right after the surgery. You don't wait for the level to drop, you get ahead of it.
Okay, to finish my answer, I'd bring it all together with a quick summary of the absolute most important high-yield points. This locks in the key information and leaves the examiner with a really strong final impression.
So, in a nutshell, hyperplasia means you have to explore both sides of the neck. The nerve is your compass. Know where to look when a gland is missing. Be ready to have an intelligent discussion about subtotal versus total parathyroidectomy. And finally, always be prepared to manage the most dangerous complications like a hematoma or a calcium crash.
And we'll leave it there with one last question to think about, just like a good examiner would. The surgery's done. When do you check that first calcium level, and what number would make you sit up and act immediately? Thinking about that question reminds us that great surgical care never really ends with the operation. Thanks for joining me for this explainer.